to slightly. It's a measure of how important Rachel is, and Rachel is to us, that we're willing to have an agenda seminar not on a Monday. This is a unprecedented change, which is a mark of how important she is and how important she is to us. So, very happy to introduce Professor Rachel Ankeny. She's a professor in the School of Humanities at the University of Adelaide, and significantly more importantly, an honorary professor here at Exeter through Agenis, which I didn't know until I was sent this thing to read.
Really?
I didn't realize that.
How do you think I'm here so much?
Rachel's very much an interdisciplinary scholar. Her areas of expertise across a whole bunch of different fields: history, philosophy, science, bioethics, science policies, food studies. So she's, very much fits in with the sorts of things we are interested in here at Agenis. And apparently she has a master's in gastronomy, which is.
You didn't know that either.
No, that's why I just have a master's in philosophy, which is very boring.
Got one of those too.
Rachel's one of the people for whom, if you tried to list all the stuff, it would take too long and get embarrassing for everyone. But it's worth mentioning her ongoing major projects, primarily some of them. One in the sort of history and philosophy of biological organisms. So she's the lead CI of the ARC Training Center for Food Crops Development. And another big project in bioethics, which is lead co-I on a project on evidence-based models for building trust and stem cell research. She's also, of course, an international partner on Sabina's project in the philosophy of open science, which some of you have probably heard about. Today, she's here to talk to us about her book project. This is a currently funded book on case reports. So she will speak on the first line of evidence, case reports in emergency situations. So
Thank you, Adrian. That's plenty of embarrassing.
Yeah.
Thanks for that. I want to start by, and Adrian will recognize what I'm about to do, by acknowledging that my university sits on Kaurna land, which has never been ceded. By tradition, we acknowledge the custodians of the land that we work on, particularly when we're there. But I wanted to do it today because we've just had a pretty negative referendum. And I think it's more important than ever to sort of raise attention well outside the country to the fact that Indigenous peoples have had their land taken from them, their customs, their language taken from them, and that we all need to do a lot better. So with that said, let me tell you a bit about the paper. So as Adrian mentioned, this is part of a book manuscript that I'm finishing up that combines quite a lot of work that some of you have read on case reporting in a range of different kinds of settings in medicine. But this is a new bit which I wanted to work in, and then fortunately for this purpose, COVID and a few other pandemics happened, and there's some good material that can be used kind of to make the point about case reporting. And so let me just start. Some of this is going to be familiar, and then some of it will go in some new directions, I think. So a bit of background about what I mean when I talk about case reports. So case reporting in some sense probably existed going back even 200 years in medicine, and arguably in other forms of clinical care, psychoanalysis notably. But it was relatively marginalized, particularly as a source of evidence. And that's kind of the point that I'm interested in here today. It's case reporting, although there's publications that are case reports, they're not cited very often. Typically, they're not the sort of thing you get funding for. And sort of the growth of the genre was very flat against a backdrop, obviously, of wildly increasing publications. This is probably in part due to the rise of so-called evidence-based medicine and the standards that come along with that, and in particular, widespread randomized controlled trials. And so case reporting by comparison is often viewed as anecdotal, N of one, to sort of harken back, Forrester wrote on N of one reporting in a different context, but probably most importantly for my purposes, that it was evidence of low quality, and tended to focus on things we didn't care that much about because it was the rare, it was the unusual, it was not the typical. And as I said, the status of evidence, some of you will recognize a version of the hierarchy of evidence. The status of evidence, it is included, so it's the red bar, second from the bottom, but it's basically the lowest kind of form of evidence, second only to random background information and expert opinion and so on. So definitely very, very far down. It is part of a continuum of so-called observational studies, but nowhere close to things that are more experimental, like the classic either randomized or non-randomized controlled trials. And so with kind of the advent or the formalization of the standards encoded in evidence-based medicine, we get, the further kind of depression of case reports as evidence. But the interesting thing is, against that background, then we see a huge increase in recent years in case reporting. And in particular, you can see the numbers over 350,000 in the period, 4-year period, 2017 to 2021. It comes to have, small but significant part of the medical literature, and maybe more importantly, over 200 journals focused just on case reporting, plus many other medical journals include case reporting. Partially this is because some journals did spin-offs because they were just too much for the regular journal. Partially it's due to the rise in very dodgy journals, but there are a number of, higher quality case report journals that now exist. Another thing to say is throughout this period, despite evidence-based medicine, case reports have always been pretty central to medical teaching, but that's not what I'm talking about here today. So when we think about, why is it that case reports sort of grew, it's clearly the case that the advent of the ability to process large amounts of data, to aggregate information and so on, in part led to this. But I think there's some other forces that come to play, as I'll try and show in a minute, about the kinds of circumstances under which you need evidence and traditional higher levels of EBM evidence aren't going to be available to you. So what is a case report? This is just sort of the general definition is something like a formal summary. It's usually an individual patient, often involves an unusual condition or a puzzle or a problem. Sometimes you get a series of case reports, but oftentimes they're connected. So it'll be a family that's experiencing similar kinds of things, or people all living in one area. It's not kind of an observational series over time. It tends to be somehow unified. But case report is sort of the general term used to cover all these things. And what they share in common is that they're highly descriptive, often, very rich detail and so on, and they're very naturalistic. So they tend not to be perhaps as filtered as other forms of medical publication. So, as I mentioned, the key thing with a case report that in a sense gets it published or gets it noticed is this idea of it being about something that was unusual or wasn't able to be understood using the typical kind of frames or explanations. It tends to use a very set, and the kind of prescription for what it contains is different journal to journal, but a narrative format. And other scholars have looked in great detail at that kind of narrative format as part of the focus on narrative in recent years. It tends to include kind of a naturalistic or impressionistic, when the patient walked in, here's what we saw, and then go through the tests, the discussion, anything else that is thought to be relevant. Some of them actually have outcomes. In other words, they figure it out in some way. Some of them don't. Some of them are sort of left open. It's for the outside person reading this, and particularly if you're not familiar with the subspecialty that the patient is within, it's just not clear why they're including what they're including. So oftentimes there's a lot of detailed data that the rationale behind it isn't always clear. Part of this is, of course, to be able to report it and then find what brings it all together. Part of it comes out of the habits and the training of differential diagnosis, which kind of defines the core that needs to be included. And some of it, sometimes it's just not clear why it's included. And it may or may not become relevant down the line. And I've written about this already, so apologize for those of you who know that. So case reports, I think, are most interesting when we think about not what they are, but what they're used for, not surprisingly. And in particular, to really notice that they're never about the patient. By the time they get written up and published, the patient is either fully recovered or dead, often dead. I mean, this is the sort of genre that it is. And in this sense, it's not about that patient. It's not a cry for assistance to solve this issue. It's looking forward to future potential patients who might evidence something similar or something that can be learned from the process of diagnosing or failing to diagnose the original patient. It often also points to new treatments, novel ways of using existing treatments, all sorts of things that could lead to either policy decisions or more practical kinds of interventions if and when a patient like this would recur. But I think most importantly for my purposes, what I want to stress is it also serves in many cases as the basis for proposing hypotheses that then can be potentially studied in much more rigorous ways, let's say, or higher up on that chart of the levels of evidence. And so in particular, it may be that you can have an observational trial, or you might even be able to go all the way to having something like a randomized controlled trial, at least of the mechanisms or something else. You're not necessarily going to induce the condition. And so here's just a smattering of some of the ones. I think case reports haven't been done any favors, in a sense, by sort of some of the traditions that surround them. So at the top, we see this quote, which is from a historian of medicine, but it's attributed to Osler. And I mean, kind of this idea that it always is something offbeat, odd, non-central. But we do see, I mean, the ones I picked here specifically kind of contrast this. We see, offbeat things like what happens after you after you apply leeches and the risks of infections. But also, as you can see, coronavirus and SARS down in the corner. So they are important in these sorts of cases where you have epidemics, and I'll come back to that. Case reports historically have really served important roles. And so everything from diagnosis of shell shock way back when, through to some of these, quite famous diseases, epidemics like Ebola, toxic shock, AIDS, we'll talk about that a bit. The kind of quite well recognized side effects now of thalidomide. All of these things were brought to attention initially through case reporting. It's often the case that new therapeutics, you're not going to have a whole series. You're going to have the first patient who receives a particular device or a transplant and so on, and then new public health threats. So the very early records associated with CJD and so-called mad cow disease and different variations therein emerged through case reporting. So I want to use the example of AIDS. Back then it was called GRID, but we now don't do that because it was gay-related immunodeficiency, I think is the D, disease. And the way in which it sort of served as a point of recognition. But I think the logic is interesting to follow for what I want to now then say about epidemics. So 1979, people will know this from some of the popular definitions probably. A few men presented with mononucleosis, but then they had all sorts of other kind of symptoms that couldn't really be explained. In the history taking, it emerged that they were homosexual. Later then, they started developing rare cancers, Kaposi sarcoma in particular. And again, the history sort of revealed that they had some friends in common and so on. So 1981, 2 case reports are published. The patients are on either end of the United States, one in California, one in New York, as I recall. And so these are the very sort of early stages of bringing to attention what came to be known as HIV/AIDS, right? The interesting thing about this, I think, is despite in the blue box, you'll see kind of the benefit of hindsight, in that people often point to it as a real classic in the case study genre. It was only cited 3 times throughout the 1980s. Now, there's probably lots of reasons for that. In many ways, these can often serve just as the jumping off point. And of course, unfortunately, throughout the 1980s, the numbers of cases skyrocketed, and this initial recognition became kind of the least important part, perhaps, of the understanding of this particular disease. So I want to use that then, if you just keep that in mind, to sort of articulate what's going on. In this case, you have these individual instances. There are 2, but they're connected in some way. People know each other, very similar kind of symptomatologies. But there's lots of information contained therein that is important to eventually getting to both a diagnosis, but often an account of the causal relations, right? So even before HIV was identified as the causal agent, these reports contain kind of clues that in retrospect we can see would have kind of given pointers. Even after working on this for quite a long time, I find it difficult to know how they knew what was important. But it's very clear, for instance, the fact that these were men, they were homosexual and they were young is sort of cited as important. They're not random, they're not just sort of contingent, but they do involve sort of judgment calls on the part of the people writing them up about what they would typically see and how this was different. And so in particular, in this instance, probably less that these were gay men and more that they were young. And they were developing sort of quite terrible diseases without having, without being older, without having some of the other indicators you would expect to have the kinds of cancers they were showing, for example. And in some way, you might think of this as similar to sort of the Hippocratic corpus. In that kind of case, there is a fairly standardized way of reporting. It's not the most exciting read if you've read some of that genre, but because it is quite repetitious, they track a lot of the same things, right? And it's structured, maybe most importantly, against a shared understanding of typical disease causation. You know, what tends to cause what? And of course, in the Hippocratic case, it's humors, it's balance, there's all sorts of things going on. In our sorts of cases in the modern day, you know, there's certain ways in which things work. Infectious diseases look one way, things that are accidental or insults look another, and so on. And so much like this kind of corpus, what you see is this shared assumptions that are never articulated about both what the norm is and what's the usual pattern, particularly of causing disease. And in addition, there's this inclusion of lots of information. The Hippocratic cases are quite pared back compared to our modern ones. So this all sounds good. It sounds like these can do work. It sounds like they're useful, but what is it that people complain about? And there's a lot of critics, particularly within medicine, who see this as not a very worthwhile endeavor, writing up case reports like this. And in particular, they're concerned about the kind of evidence they provide or the lack therein. And the complaints are, you know, kind of familiar to those of us who do philosophy of science, particularly. They tend to be focused on individual instances. They're very detailed, but they're only about particulars. They're not about generalizations. They're not experimental, as I mentioned before. They're more observational. They seem in this sort of narrative structure that's like storytelling to obscure some of these patterns that we would expect. And it doesn't seem to be a methodology that you can narrow down that helps you to understand why things are included or excluded or the points of emphasis are put in. And that last point, I think, is absolutely correct, but in many ways, that's kind of the strength. But part of what I want to try and argue is, I mean, much like other areas that people in the room have written on, historic sciences, where you do have things that are rare or unique occurrences or singular occurrences, they still can be explained and evidence can be gathered from them so long as you know how to use what you're presented with. So the other complaint that typically people make is that medical case reporting is an inductive undertaking. And here the whole idea is that, you know, in some way you're just collecting instances and they don't necessarily add up to anything. And that kind of criticism hinges on the notion that they haven't been randomly selected. There doesn't seem to be any of the typical things we would look to in place as a check and balance. But where I think that kind of criticism goes wrong is whether it's useful or not isn't, you can't determine that in the abstract. You have to think about what is the question you're trying to answer. And so case reports are not used to come up with frequency for something in a population or to look at common conditions. That's not what they are for. So in fact, you know, they are doing a certain kind of work, but that is with reference to the unique, the unusual, and so on. The further point I want to make then, and this gets us then into another form of reasoning beyond sort of induction, is that case reports serve as this jumping off point for proposing hypotheses, either to be tested, you know, by the group proposing it or by others, in order to then move into other forms of medical research that might tell you more generally what is going on. And that's a different form of reasoning, as I'll go through in a minute. So let's return for a minute to AIDS. That's exactly what happened in this sort of case. These original cases, even before they were printed in Mortality and Morbidity Weekly Report, which is sort of the US CDC reporting mechanism, they got out there. There was lots of discussions in sexual health clinics, in gay men's circles, amongst doctors who treated lots of young men and so on and so on in the big cities, that this was going on, this was being seen. So people start watching for similar patients with similar symptoms and so on. And the CDC does start to track it. So again, sort of the tracking replaces perhaps the citations. The selectivity of what's included, as I mentioned before, often signals what people who are writing up the case, the clinicians and otherwise, think is most important. So even if you look at the headline, in some ways they thought the Kaposi sarcoma was important, not necessarily because of the precise kind of cancer, but because it was unusual. It was usually only seen in elderly men from the Mediterranean. So to see it in young men was really unusual. And the severity of the kind of pneumonia, as they described it, that they were seeing in these men, also not seen typically in young men. And so in some sense, the fact that they were otherwise healthy young men means all of this requires more explanation than it would otherwise. Because in some sense, you can just say, oh, they developed cancer. There's certain mechanisms for that. Oh, well, they got, pneumonia, and we kind of know how that works. That doesn't warrant an explanation or even maybe additional attention. We know how to treat that. But it's the conjunction of all of these things, and in men who otherwise seem to be healthy, that requires then the explanation. And in these case reports, there really is this focus on the idea that they're gay, and it's not really explained why, but it does seem as though there was an intuition, because there was a lot of discussion in the community, if you've read any of the sort of lay histories of this, that something was happening, that in many ways kind of undergirds the mentioning of the fact they knew each other, they were in the same circles, and they were gay. And this is contained along with, blood pressure and other things like this. So what I'm trying to argue in the bigger book is this idea that case reporting in many ways should be seen as a form of abduction. And now some throat clearing. Abduction, of course, has many different forms. Hearst is sort of notoriously has different versions of different things. But I do think there's some, common features we could boil out of it. One is that abduction almost always starts from a series of observations, and then you seek a hypothesis based on those observations. Hearst uses nice homey examples. It's sort of like 20 questions. If you get good at playing 20 questions, you can choose a very informative question that's going to rule out a lot. And when you do that, that question may well be super, point to something that's super unlikely to be what the person has in mind, but it also lets you rule out a lot. And so he stresses this notion, in some ways it's kind of a critical test, but almost an inverse of a critical test, the idea that you can formulate some very precise things that you can test for to start to then rule in and out, right? And so what happened in the case of AIDS was that there were a series of hypotheses about transmission, for example, many of which came to be disproven. So these men also were part of the same sort of party circuit, and they were using certain types of drugs. And there was the thought that perhaps the disease was spreading through use of these drugs, and that was examined and ruled out, and so on. So the rich kind of details of the case study were filtered through over time. It's hard for us to see in retrospect how it wouldn't have been obvious that this was sexually transmitted and a bloodborne disease. But again, this wasn't the sort of thing that had been seen before. Now we sort of are more open to things that work in that way, but it wasn't something that was expected. So where it went from there, sort of in the historical, very quickly, there were over 200 men identified in 3 different locations, but there were locations that were connected, where people traveled and again, were part of many of the same circles. And this then solidified kind of the remaining hypothesis was that it was infectious and sexually transmitted. But then, of course, what happens is you get something new in the mix. And in this case, this was emerging cases of something that looked the same amongst hemophiliacs, IV drug users, women, recent immigrants, men who didn't have sex with men, and each of these things allowed refinement of the hypotheses and the understandings of the causation. All of this was then studied via observation. You're not in any way going to do a randomized controlled trial to understand disease causation, particularly this sort of thing. And so you can see why I'm trying to argue that case reports are really important in these kinds of contexts. Now, the obvious question comes, given that, you need to have this idea of a hypothesis being informative or well chosen, how is it that what are the standards by which these are formulated? They're very context specific, they're very pragmatic. How do we know what people tend to pick? And I want to say that case reporting often proceeds by being strategic in a sense that Jaakko Hinnekka and others have mentioned it, a strategic use of certain kinds of hypotheses, again, along the lines of the Peircean ruling out kind of approach. And they are correlated with the ability to then pursue an investigation of some sort. So the kinds of hypotheses that are usually proffered are not things that you can't look into. So there's a correlation in some sense, and in that sense, it is very pragmatic with what you're able to do, either ethically, practically, or otherwise. And those tend to be the kinds of hypotheses that are then put forward. So we have this real hybrid going on in some sense of observation through additional clinical instances or observations, together with being able to study some of the underlying processes in more of a biomedical research setting, maybe more in an experimental or a standardized way. So because in medicine, so much of this is a hybrid, I think sometimes we tend to look for the ways in which it falls short of being kind of the standardized research frameworks that we would expect. But what I want to say is it's also important to look at what people actually do in these settings, which is another form of practice. So in addition, as I already said, any hypotheses that are put forward have to have something that can actually be tested. And in particular, there are often the weighing up of sort of plausibility conditions, and this background knowledge kicks in about what the typical would have been in this domain and how this is different from that or similar to it. This is one of the advantages of abduction in many ways is at the same time as it narrows some of the options, it also still leaves open room for new things to come into the mix, right? And this is partially because the process of abduction is typically iterative in some sense. And so in the case of AIDS, the idea that it was infectious was plausible because you could see kind of the way it seemed to be spreading, but it also accounted for some of these observations that were different than what might be expected. And I've already stressed the idea that people were young and dying. So abductive reasoning in this way, and this is something that Peirce writes a fair amount about, is creative. It allows new information to be put in the mix. It allows new theories. And therefore, unlike induction, where it's just sort of more of the same, or deduction, where it's locked down by where you start, the logic, you can't go beyond what logically is given, abduction allows this sort of entering of new information potentially. And it's really important to understand that it provides a sort of inferential process that has its own rigor. It's just a different sort of rigor than induction or deduction. And in particular, it really hinges on formulating hypotheses that are testable. And so I think Peirce's kind of account makes much better sense of these sorts of cases and case reporting more generally than trying to make them fit some of these other forms of reasoning. Finally, just this is all sort of background. Case reports are also really valuable because they allow dialogue. And in many ways, that's another part of what abduction allows, because it allows rich material to be created and discussed. And this is kind of a communicative kind of point, but it also has to do with the shared understandings in the medical communities in question of what kind of the rules are for certain kinds of disease processes, and then how to understand when these rules either appear to be violated or something is behaving in ways that is a deviation from what we might have expected. So when a case report is published, it often, as I said, doesn't have the outcome. Sometimes it does, but often it doesn't. The idea here being that the hope is that others can work their way through it, see additional instances when people present to them, or perhaps can see something in the case material that the original reporting physician didn't see. Now, not all case reports are successful in the sense that, I mean, it depends on your measure of success. Many of them end up with absolutely no citations. I've gone on wild goose chases sometimes with very interesting ones to figure out what difference they really made. And you see absolutely no one ever cited it. It's a bit difficult to sort of wait around for a case to be used in real time. But I think it's less important kind of how they could have been used, but how they are used. And so that's why I tend to look at the ones that are picked up. In many cases, we see, you know, falling short perhaps of the ideal. But I think what I'm interested in is when the practice works well, what it looks like. And that's why I focused on the more successful ones. So I think another takeaway from all of this, it's a more general takeaway for philosophy of science, is something that we all know, but it's good to be reminded of, that not all science focuses on explanations. And in particular, these kinds of medical evidence, case reporting, again, is really focusing on the further inquiry. They're not always looking for the causal relations that are going to explain why a disease developed. They're really at a much earlier stage of practice than the one where we'd expect a full-blown explanation. So in many ways, they're a very sophisticated or detailed way of presenting those very early stages of scientific investigations where you have evidence, lots of details, but you haven't gotten to the point of explanations. So now I think, sorry, now I've got everybody back in the room. I want to focus now on, it doesn't really matter, there we go. Focus on emergency situations, and against that backdrop, try to show you why I think case reports are extremely important in these kinds of instances. So, not surprisingly, case reports are really typical where time or other practical concerns don't allow for randomized controlled trials or even observational controlled trials, where resources don't exist. And so the other interesting thing here that I'll be able to show you in some of the later slides is that we see case reporting really kicking in settings that are under-resourced, right? Because it's not necessarily the case that everyone everywhere can do randomized controlled trials or even observational trials up that hierarchy of evidence. So instead, you know, there are certain forms of evidence gathering that are accepted in these more under-resourced kinds of either locales or specific settings. But you need evidence, and ideally you need good evidence, right? And so how is it that case reporting can serve as a type of evidence that is useful, and what kind of way, in what ways does it work? And I think some of the recent pandemics, not just COVID, but some of the others, give us some data and some interesting reflections about how they work when they work and how they fail to work when they do. There's certain conditions that need to be met in order for them to function well. So this goes over to Sabina and John wrote about process epistemology effectively in COVID. And they talk about this process of reification with particular reference to the virus underlying COVID. So SARS-CoV-2, very, as we all know, unstable virus, changes very rapidly, evolves like all biological things do, or most do, in response to the environment, without response to the environment, and so on. And so they make the argument that reification is generally an important thing when you're trying to sort of stabilize a phenomenon that you're trying to study, but that you always have to be aware that you're engaging in that kind of reification, that you're idealizing, if you will, reifying is what they say, something in order to pin it down. If you don't recognize that that's what you're doing, then everything that spins out from that reification is going to be problematic. And in particular, the kind of data and the models based on something that is not static being treated as static, homogeneous, singular, depending on the kind of thing, right? And so in the case of COVID, what we see is that, again, sort of big data tools were very important. Data mining and other things were used quite effectively to gather up a lot of data. But the problem was they tended to assume that the object, the virus in their case, was static. And they make the point that there were few systematic kinds of provisions for capturing changes in the phenomena and responding to those changes. So that the virus was changing over time, it was changing in different places in different ways, that it was really important to know the provenance of the data, because that tells you where and when it was collected, which may then in some way put it in a different part of the story about the virus and its evolution and so on. I'm focusing on that few systematic provisions because I want to say that in many ways case reporting serves as that kind of vehicle that they're looking for, so long as certain things hold. So let's back up a minute now and talk about influenza instead, H1N1. And in particular, there was a great effort in that pandemic in 2009 to collect case-based data. And the World Health Organization was really focused on, for various reasons, the first 100 cases in each country. So it's kind of a funny data set, but they were really interested in the laboratory confirmed cases, and they wanted to try to see how quickly these things spread, et cetera, et cetera, et cetera. So they received tons of case reports, way beyond 100 for each country, but the data was extremely inconsistent, despite the fact that they had provided kind of forms for people to use and tried to train people up and so on, in part because it's a pandemic and you can't actually necessarily at that point train people up. But they also, reached the World Health Organization at very different points in time. Some of the data came in very late. They didn't tend to include full information, particularly about how all the data was collected. So they're missing a lot of the important kind of points that typically should be contained in any kind of case reporting. And what you see here, and there's several things you can see here, the darkest things are Europe, and this goes all the way through to sort of the light is North Africa, Middle East. You can barely even see that, just sort of on the top. But notable, for example, is Sub-Saharan Africa in the light yellow. You can see the very different time points, but also the very different kinds of patterns of the 100 cases. And to a certain extent, this made the WHO investigators retrospectively say this wasn't a very good instance of data collection. So why? What was their diagnosis? Here they said, instead of just collecting the first 100 cases, it was probably going to be much more important to identify really critical questions about infectivity, transmission, and other things, standardize the data elements much more firmly and much more rigorously, and also the methods of investigation, no surprise, but also develop better means of communication and so on, because otherwise by the time the data flows through, it's just too late. And most importantly, it's just useless, right? And so there's a lot of parallelism here more generally with case reporting, because what we see is that the need to articulate questions that the case report is seeking in a sense to answer is an important part of the picture. The need to standardize the elements, very important, but also having communication channels even across under-resourced locations. And so it is the case that case always comes up way too much. In case reporting that they've developed a set of guidelines now through consensus that there are sort of certain things that have to be reported over time. And the goal here, not surprisingly, is to try to increase the completeness of the minimal data set and also potentially allow in the long run the ability to process and amalgamate these using big data kinds of techniques and so on. But they also point to the need to have more transparency in some sense, including for future users. And so this has to do with the notion that sometimes the information isn't necessarily clear till later, and therefore it's really critical to have as much as possible short of recording everything about a patient, right? So if we then think about the case of COVID and COVID surveillance, what we see is that something similar occurred to what had occurred with influenza, and not just that pandemic, but others. And the aggregated data from case reporting provided some information that was important and interesting. But looking at it retrospectively, practitioners in epidemiology have really noted that probably disaggregated data was more valuable than they realized. And particularly if you can have fairly complete reports along some standardized kind of metrics, standardization of the kinds of measures that you're using, and timely data sharing, disaggregated data could be useful in its own right. And so that means effectively case reporting. And they really stress the notion that case reporting is going to be particularly important in places where you don't have ideal conditions. And so case reports of what worked and what didn't are going to be really critical in places that may not have the most cutting edge equipment or the best sort of standards. And they call these sort of fragile settings. And I think what's interesting in COVID is we really saw that many locations that might not have expected it in some ways became these fragile settings because they were either overwhelmed with patients, there were limitations because of government policies and so on and so on. And so in this article, they call this particular group of scholars calls out for, in some way, really making the recording of individual disaggregated data a more prominent undertaking, something that's important to do. It's not just all about aggregation, getting the averages, but that it is important to get these individual instances in many ways. And in addition, there needs to be, not surprisingly, much more empowerment institutionally, but also of those in the healthcare fields to be able to gather this kind of disaggregated data. And that it's especially important if what we're concerned about isn't just kind of the averages, but having some sort of equity in healthcare that allows responsiveness to the non-ideal conditions, to the under-resourced conditions, to the diverse range of ways in which even a very standardized disease can be seen. So when we have something that's highly volatile, mutating, changing, it may be even more important to have this range of data points that comes out of case reporting. And so I'm not going to go into all of it, but just to highlight, that's one example of the kind of case reporting. But in COVID, there was all sorts of layers of case reporting of either patients or suspected ones around the nature of the infectious entity, obviously, the period of infectivity, whether certain drugs worked or didn't. Case reporting was super important around the toxicity of some of these drugs that people felt the need to try. The difficulties in diagnosis, particularly where you have comorbidities. So again, case reports are real patients. They're not, healthy volunteers that otherwise would be fine. They're people who have multiple things wrong. And in a pandemic, it's important to at least start to develop a typology of the person who already has COPD and gets COVID, or the person who already has something. And case reporting starts to allow kind of that clustering again of these sort of real life kinds of circumstances. And then also novel findings. And so we see fairly early on instances of what we would probably call long COVID in the literature, sort of noted as puzzling findings. Some of them may have just been a variant of COVID or coexisting conditions, but in some instances you start to see things that look like long COVID. And so some general lessons. I mean, obviously in emergency kinds of situations, there's the need to have evidence and to be able to rapidly make judgments, both about what to do, but also the policies around what to do. There's trends because we do have the abilities, computational and otherwise, to use large amounts of information to do that. But as we do that, it's going to be important not to lose track of what combines together to make kind of a set of data. And in particular, cases serve a really important purpose of being able to give perhaps a continuum or an extent to which things appear in certain ways, in addition to giving averages and baselines and so on and so on. Not surprisingly, they only work well if you do it well. And so unlike some of the criticisms of case reporting, people who engage in case reporting fully understand you need to in some way standardize. It's not just anything goes. You need to share these openly because otherwise they're pretty useless. They don't have a lot of purpose in and of themselves and so on. And I think more generally then, in cases of emergencies, but particularly things like pandemics, these kinds of cases point to the idea that there's the need to be more open to the diversity of evidence that might come in, but always be cautious about what it might be evidence for, and that these are distinct kinds of questions. And so I think, more generally, this is something that can help the reputation of case reports, is this kind of recognition that case reports are important in as much as they allow capturing of fluidity and change over time. They allow us to see ways in which diseases are never really static. They're happening in real time as biological entities, particularly when they're infectious, and that case reporting allows this kind of journey of any particular disease to be reported. And in addition, the cases themselves can be sort of contrasted and compared, and they can be seen as ways in which we can see the evidence both accumulating and also changing. But this does require the systematicity of at least the minimum amount of information. I think, and there's a different chapter in the book where I look at using case reporting as a way to enhance care in under-resourced settings, and ways in which physicians use these kind of one-off reports to provide more effective care to people who otherwise don't fit what's in the literature. And so where they don't have the most cutting-edge pharmaceutical available, where they might not have the ability to image in the ways that they're able to image in higher tech settings, and so on, we find physicians often turning to case reporting to find a way into responding to patients. And of course, this is going to lead me to putting in a plug as usual for the fact that science never occurs in isolation. All this stuff is always shaped by things like resourcing and financing and social political kinds of settings. And again, I think case reporting in some way mixes that in. Often if we see a randomized controlled trial, it could be anywhere. It's being done with, idealized patients under ideal conditions, and so on and so on. Case reporting is exactly the opposite. It is done in real time in real places. And, in case reporting, we hear a lot about people's histories. And this in turn, makes it a more realistic set of data for anyone trying to engage in clinical care. And so in turn, then I want to say this is a form of abduction. The goal of any of these things is not to evaluate the likely truth of a hypothesis. That's not the primary goal. Instead, it is to establish kind of an interesting problem, if you will, that then can get followed up. And in many ways, Loudon made the point that we need to constantly be making this idea of pursuit worthiness judgments about what you follow up on and how you follow up on that. And that's part of what the narrative does, is provide these pointers as to the most likely kinds of hypotheses that then warrant perhaps more investigation in the usual rigorous way. But again, abduction also has the advantage that it is iterative and that it explicitly leaves open. It doesn't have, in a way, an ending or a conclusion. And case reporting very much has that kind of feedback loop in it. So I'm interested in case reports, not surprisingly, because they are instances of actual practice. They're not textbook medicine. They're messy, they're complicated. Often they're not solved. And I think the reasoning that we see in case reporting is interesting because it does sort of exist in this in-between space between the individual who walks in with some problem and some desire to generalize. But there is this notion that in many cases, this is never going to be generalizable in the fullest sense. The details are going to matter, but that doesn't make it not useful evidence, and particularly when in clinical settings, the individual does matter. All of this, of course, is sort of using a science and practice framework. Even if I'm not going and sitting in the clinic, I think the case reports give you a window into what goes on when someone comes in with something wrong that's unusual and so on. And I've tried to argue that I think this kind of case reporting, rather than being seen as kind of the weak sort of publications people only do when they're desperate, is actually a really important source of evidence, as long as you understand what it can be used and reused for. So thank you.